I begin this segment with a confession. Just about 4 years back was the first time I came face to face with crisis of a sickle cell anemic patient. I never knew what it is. I used to hear about it. It was very touchy, it was traumatic, and it goes to ask the big question, what do people who have children, brothers, uncles, sisters go through when they have this class of persons amongst them? But the interesting thing is, because of the fact that they go through a lot of medication to stem crisis, a new trend has been discovered. They have been known to be going into drug abuse now, and that is also worrisome. A sickle cell anemic patient who manages crisis going into drug abuse. So that will be the focus of this segment of the program. And on set with me, I have Dr. Anireto Chika. Dr. Anireto Chika is a consultant family physician trained in cognitive behavioral therapy. And I must say she's the behavioral therapist, right?
Yes.
And she's of the Cedar Crest Hospital, Abuja.
Yes.
Good to have you on Inside.
Thank you.
And Hawa Usman Sani, she's a sickle cell patient and co-founder of Strong Cell Foundation. Good to have you on Inside.
Nice to meet you, sir.
Okay, let's start with you because I was triggered to bring you because of you. Now you have a foundation. When do you come to know about the fact that your class of persons are into drug abuse?
I got to know about this from my own personal experiences. And I would say there's a lot of misunderstanding with this on both the society's side and as well as the medical practitioners. Because I am a sickle cell patient myself, and you need to understand what a sickle cell pain or crisis is. They go through all manners of complications. The AVN, which is a deep, serious pain that might require surgery, and then the frequent crisis that could start at any time without any trigger, any direct trigger sometimes. And you can imagine it's compared to labor pains. So it's very easy, and the only way you can tame this is through rehydration and then painkillers, and then to get to the root of it, which might be infections or something like that if there's a cause. These painkillers, compared to, sometimes you go to the hospital. For me personally, to answer your question, you get to the hospital and you give me paracetamol, maybe the injection or the tablet. It does not help sickle cell crisis pain. We move to the next level. You say, okay, diclofenac. Sometimes it helps. Those are different drugs that they give. Or you get to pentazocine, which is mostly abused, as well as tramadol. You give me that, and then it relieves the pain for maybe some minutes. And of course, it's very easy to say, once the pain comes back, give me this again. So it's very, very easy to step into the boundaries of substance abuse.
So how did you get to discover it? That's my point of concern.
You get to the hospital sometimes, and then you are in pains. Like for my own personal experience was 2010. I had a very bad crisis. It just started at midnight, and my friend rushed me to the hospital near her house. Then she took me to a government hospital, a prominent government hospital, popular. And when I got there, they said they were looking for vein to give me this. I said, please, the first thing you're supposed to do is to manage the pain. They said, it's like you abuse drugs. I'm like, no, this and this is what works for me. They said, no. Before I knew, they had written on my file that I was a drug abuser. And they refused to give me that pain. They came and gave me, was it diclofenac or something? It did not work for me. I got there at about 10 p.m. Nobody attended to me. The doctor came to see me at about 5 a.m. and said I was opium dependent. That was what they wrote on it. I am not, for God's sake. I've never given myself an injection. I only take it when it is absolutely necessary. And it was the next doctor that came on call at about 8 a.m. that looked at me and
from
smiled.
The previous night.
Yes, I was almost dying. That came and was like, this is a sickle cell crisis and she's very bad. She gave me just one shot of Penta and I was fine. I slept off. By the time I woke up, she followed it up with a diclofenac suppository. I was good enough to go home by night. Would you call me a drug abuser? Because I needed something to ease my pains.
Okay. All right, doctor. you have heard, would you call it a touchy story?
Yes, I'm actually sorry that you had to go through all that.
Let's hear your response to this.
Yes, so I wasn't there, but from what you've told me, I think the reason why doctors are hesitant to prescribe opioids or are very wary of opioid dependence is because of the propensity of those drugs to be addictive. The relief that they give is so profound that we understand why patients who are given those drugs would want to take them again. And then again, it's not to belittle the severity of the pain these patients have, but it's because we are wary of causing another problem in addition to the one they presented to. But we as practitioners, it's a thing of trying to balance between pain relief and giving just enough not to cause dependence. So that's what I'll say about that. But it's a very real problem. We do have patients who have gone over the boundary, so to speak, and have actually become dependent.
So what would you say about the doctor who sentenced her to opium dependent?
I'll say
without
that
investigation?
He or she was trying to be too careful. And in our profession, we'd rather err on the side of being careful than to err on, we don't want to make the patient's illness worse. We don't want to add on. So I think the doctor erred on the side of being very cautious, which is what we manage this? The addiction.
Yes.
Okay, so let me start off by saying we know addiction means it could be psychological and physical. So the psychological aspect is what I'm trained to handle, but the psychiatrists do more of the physical
Let's hear about the
treatment.
psychological now.
So in someone who is psychologically dependent, and this is not only on hard drugs like the opioids she mentioned, the pentazocine, morphine, which is stronger than pentazocine, other less sinister, in quotes, like nicotine, smoking, and caffeine can also be addictive. But let me leave that for another day. Okay. So how it's approached is, let me explain what a cognitive behavioral therapist is. Cognitive behavioral therapist is someone who is trained in psychotherapy using cognitive behavioral methods. And that just means based on what we call the cognitive model. And that is that there is a relationship. As a family physician, I'm trained to look at people holistically. So not just their physical body, biomedically, but also psychosocially as well. So that's why I got this additional qualification. So a cognitive behavioral therapist looks at the relationship between someone's thoughts, the situation, the thoughts, and then the physiological reactions, the emotions, and then what the patient does. So using Ms. Hawa's example, the situation was she was in pain, and that is very real. Some of the thoughts I've heard from people who have been in her position is that this can never get better. This is not fair. Why should I have to go through this? And then there is the emotion of sadness. There's some anxiety, some fear. Maybe this will be the last crisis. Maybe after this it will be all over. And then eventually, when they feel better with the medications, all that goes. But some people even progress to a situation where they now want to harm themselves. That's another topic altogether. So what the cognitive behavioral therapist does is to be able to identify those thoughts that we're responsible for the emotions.
Have you come in contact with cases like this before?
I have, actually. I have. So I'm actually imagining one right now as I'm telling you this. So what we do is to try, because the thoughts are real to the patient at the time they're occurring, but they may not be facts cast in stone. They are ideas, but the body responds as though they are facts and acts as though it's a fact. So imagine someone who already has a very physical pain, like the pain she described, in addition to fear of death, fear of this being my last crisis ever, and then anxiety about what would happen, what kind of future do I have? This is how I'm going to have crisis over and over again. And then some sadness, some depression. So all those cognitive or emotional aspects worsen the pain. So where the CBT therapist comes in is to look at the thoughts and see whether are they really facts or they're more of ideas or the perspective of the patient, and in so doing reduce that other aspect and then reduce the pain. So we work in conjunction with the psychiatrist, with the hematologist, because pain, the psychology of pain is not just a physical thing, it also has these other aspects. Okay. So we try to reduce these other aspects and then in so doing reduce the pain. Okay. I hope that is
absolutely. Well, great. Oh, wow. I know you run you co-joined, you run an NGO called Strong Cell Foundation.
Yes.
Is it all about your class of persons? And
Yes.
what do you do?
Okay. Strong Cell Foundation, we came together, I and my friend, we're both sickle cell patients. And we believe that despite the challenges and pains we've gone through, we've been able to push ahead, forge ahead to build on our careers, live basically relatively successful lives. I'll not say 100%, but then we thank God for where we are. We have a career.
She's not my G.
I have a family and all that. And then we see so many other sickle cell patients struggling, and we know that we struggled to get to where we are. So how can we spread our wings and then help other people along? We have issues with management, sustainable management policies. Most times, because it's recurrent and it happens so frequently, we find it difficult to manage it. You mean you're coming out of one sickle cell crisis, you've spent all your income managing it, and then another one happens. And it affects you mentally, psychologically, socially. There's so much stigmatization in the workplace, in your family life, you understand? And then we said, how can we help people? How can we be a voice to come together with other NGOs as well and help other people achieve, if not more, at least get to where we are now? And that was what led about to Sickle.
So do you have some of your colleagues who are into abusing drugs because of their situation?
Yes.
So how are you managing them?
Most of them end up in rehab. That's the thing, to get over those drug abuse. And this drug abuse is so bad that it could cost you your life and your limb. I have friends that give themselves pentazocine injections on their laps, and then they swallow tramadol because of the crisis pains. Or when they say that, okay, another one is coming up, I'm feeling funny, let me quickly give myself this penta. No, you have to watch the threshold of your pain, and then to know what works for each phase. Not that you just wake up tomorrow, maybe you are having a 1/10 score pain level, and then you go and start giving yourself penta.
So will you say that your NGO is picking up?
It's picking up because
in terms of what you aim to achieve?
Yes, we just had our first unveiling and maiden program, and the topic was mental health, because we wanted to tackle it from that angle, renewal of the mind. And we went through mental health. The topic was managing mental health and sickle cell disorder, and we had a whole lot of hematologists, psychologists, and psychiatrists on board to talk to caregivers as well as the patients themselves. And I would say, to the glory of God, it was a huge success, because alhamdulillah, we didn't expect it to be like that.
Was the media there for you?
The media, they all came out and they ran with the topic because they felt this is what is affecting the society. Not even just sickle cell patients, other people are going through depression as a whole as well.
Okay, Dr. Chika. Awaw happened to be a grown-up woman. She even has, how many children do you have now?
I have one.
Okay, one. You see there?
Yes.
Now, you have people who are not of our age, who are still dependent on their parents. Some don't have families yet, both male and female. What word of message do you have for family, friends, and people of this class, so that what she has come off to do, some have not been privileged to know that they can do what they're doing, and they veer into drug addiction?
Okay, what I have to say is, whatever you're going through, it's not, don't think that you're alone to start with. There are people out there who can help. There are people out there who are trained to help. People like myself, people like the psychiatrists, people who may not be sicklers ourselves, but by virtue of our training, we are aware of the level of pain you're experiencing. Because I think isolation also doubles the pain that these people have, the feeling that you are not understood and that you are stigmatized and nobody really knows what you're going through. So there are people who are trained in this. For the friends of people like this is, please pay attention to your friends. Take note of telltale signs. There are some signs that you'll be able to identify, and you'll know that the person has gone from ordinary taking medicines for pain relief to being addicted. So signs like having a low frustration tolerance, someone who could tolerate some level of irritability, stress, and all of a sudden little things trigger the person. That's one of the signs. And then wanting to be alone all the time, withdrawing from people. Self-care suffers. The person might not take care of themselves as they used to. Person might not eat well. Person might begin to lose some weight. The mood the person has as well. They could either be sad, excessively sad. We use the word depression very cautiously because actually diagnosis could be actually very sad, or behave more excited than you know the person to be. So these telltale signs are things that you as parents or friends should identify, and please do not try and tackle it on your own, because this is a real illness, the way we have hypertension and diabetes. It's not that the person is doing it on their own. The person is a victim. The person is ill. So it's not something you should say, you should have more willpower. Why can't you get over this? It's way beyond that. It's that the body has come to a situation where the body needs this medicine to survive. So the withdrawal symptoms these people experience is very real. And if you were in their shoes, God forbid, you would behave in the same way. So if caregivers, family members see it like that, they will be more compassionate.
Can you just touch briefly on affordability
of the care? Because,
I mean, that's another problem.
Well, good enough we have insurance these days. So the truth is, it's not as it could be in terms of affordability. That is true. But because of the presence of healthcare insurance now, NHIS, HMOs, so the cost of care has been reduced and the patients don't have to bear the full brunt. So that's what I'll have to say in that regard.
Well, before we go, could you just lend a word of advice to your friends who are into addiction, that you have established an NGO to maybe see if you could take them off where they are?
Okay. What I would say is, yes, I understand that the pain is bad because I feel it too and I know. And we care. That is why we started this. Like Dr. Anirito has said, please get help. Once you start seeing yourself taking pentazocine, taking tramadol or morphine for any little pain at all, do not be afraid, do not be ashamed. Kindly look for help. Like she said, there's HMOs now, and then by God's grace it will get bigger, and then they will have less restrictions on pre-existing conditions, which they do presently. And that is a problem. The government should actually tackle that. This embargo on pre-existing conditions that some HMOs bring on. Keep taking care of yourself and be positive at all times that tomorrow is going to be better. Definitely.
So how old are you now?
I'm 36 today.
Wow. Because I don't know whether I'm how to put it, ignorant now. We hear sickle cell patients don't get up to 21 years. Is it true?
I'm 36.
You're 36 and you have a baby.
Yes.
So there's hope.
My professor in medical school had sickle cell. Okay. So yes, and he's a professor. Okay. So yes, they do live long.
Is there a period you get to and you are out of it?
The sickle cell disease?
Yes.
No.
Oh really?
No. It's an inherited disorder, so you're born with it and you live with it. So patients
as we
are
go,
taught.
Can you also give us hope? She has given us her own aspect of hope. Give us the therapeutic aspect of it.
Okay. So what I always do with my patients is there are reasons for living. What we try to do is, because that mindset of I can't stand this is not fair, why me? It's transient. But the problem is that people act in the moment and take rash decisions in the moment. But the truth is, if you could tell yourself, count the reasons for living, and you realize that there's so much to live for, both because of the ones who love you, the ones who you love, and think about what the future would be without these ones. So that's what I try to do. I try to get my patients to look in that aspect and count their reasons for living. And when they see it that way, then perspective changes, and then the chances and the tendency to want to either go the route of taking more medication than they need as far as addiction, and then suicide also reduces as well.
Well, what will I say? I'm well informed and well placed to even do maybe first aid if I found myself in a situation right now. Well, Hawa Usman Sani, co-founder Strong Cell Foundation, it was nice having you on Insight.
Thank you very much.
And Dr. Anire Tuchika, consultant family physician, trained in cognitive behavioral therapy. Thanks for joining me on Insight.
My pleasure, completely.
Well, you got it all. Up next on Insight is the media review segment. Don't go away.